be a bifurcation case with imaging. So perhaps we'll make a start, and our senior interventional fellow Tushar is. So this is a 74-year-old gentleman who has a background of previous liver transplant for hepatocellular carcinoma and hepatitis C cirrhosis and type 2 diabetes. So he presented via our heart attack service in about 6 weeks ago with an inferior posterior STEMI. Next slide. So he was taken straight to the cath lab where he was found to have an occluded circumflex, which was treated with a Promus stent 2.75 by 28. Next slide. The right coronary artery was unobstructed, and in the LAD we found this severe mid-vessel lesion with quite a significant step down in size from the proximal to mid-segment. Next slide. So post-procedure he had an echo which showed some mild LV impairment. He had a mild transaminitis and was reviewed by our liver team. He was subsequently discussed at our MDT, and it was felt the best thing to do was to do a staged PCI in 6 weeks of the LAD using a stentis with OCT guidance, and he was discharged from hospital on day 3. So next slide. I'll now hand over to Dr. Lockie to talk a bit about stentis.
Thank you very much, Tushar. So the stentis is a novel stent. It uses self-opposing. It's a nitinol structured stent and comes in a variety of sizes, sirolimus coated. And the new Exposition S, it's got a novel system where you have a balloon on the inside with cracks of sheath which surrounds the vessel. The balloon then, the sheath then peels away. The stent expands into the space, opposing very, very nicely, especially in these very ectatic and discrepant vessels. And then you withdraw the sheath, which is trapped behind the stent, and then you post-dilate as you would do normally. And we felt that given the anatomy of this vessel, I think getting a good result with conventional technology would be very difficult. So we're now going to move on to the case. We've taken a couple of setup shots, including some OCT using our 3D co-registration system. So we could go now onto the OCT pictures, please. Go onto the OCT feed. So we started off by taking some distal reference measurements, which showed a diameter of around 3.5 millimeters. And then if you look at the proximal, or sorry, the mean lumen area, the tightest part, you can see there's quite eccentric piece of calcium, and there's a tight lesion in the middle there, which comes all the way back with a MLA less than 2.5, which is obviously very significant in a big LAD like this. You can see the eccentric calcium at the bottom there. And then if we come to the proximal vessel, you can see it's very, very ectatic and large, with a mean lumen diameter when you go from the of around 6 millimeters. So I think to get a good result in or 5.7, 5.8 at the maximum. So I think to get a good result with a normal stent that wouldn't overexpand and dissect the vessel distally, get good apposition throughout, and then get good apposition at the proximal ectatic region is why we selected this device. So I think we'll crack on with the case. We haven't got too long. And I think the first part, we're going to start doing some pre-dilatation. I think lesion preparation is absolutely essential in these cases. These are not self-expanding stents, they're self-opposing. So you need to be absolutely sure you've debulked the lesion to minimize the risks of stent recoil, because in the earlier trials with such technology, this was one of the problems. So I'm going to hand over to Robbie now, who's going to start pre-dilating. First of all, we've got a Emerge semi-compliant balloon. And we'll just get started. I'm wondering if any on the panel have any comments or thoughts about the setup angiograms and our approach.
Can we maybe just run the angiogram with the guide, just so people can see? So this is an EBU35 guide.
That's a fascinating case. Yeah. Was your choice of the stentis device, is it approved in the UK, or is this part of a study? And
it is, yeah.
You picked it based upon this aneurysmal area approximately, or tell us a little bit about your logic behind the choice?
Exactly. I mean, it's fully CE marked in the UK, and it's in quite extensive use in European centres. We chose it for several reasons. I mean, I think first of all the anatomy of the region. I think that it's very unpredictable how you're going to get a good result with a conventional balloon expandable stent. I think we know that when we start taking balloon expandable stents up to around 6 millimeters, that you get a loss of stent integrity, you get loss of deformation, you get loss of expansile strength and support. I think you get prolapse of tissue, and I think that although it is possible, I think that the optimal result here from a dedicated device would be much more favourable. I think also with a distal reference of only 3.5, if you wanted to get up to 6, you'd be looking at one of the bigger platforms like the Promus 4mm or the Onyx 5, but I think that would be too big distally, and to avoid using overlapping stents as well, we feel we can get away with a single device here.
And then in terms of the sizing of the device, are you just trying to obtain apposition?
Yeah.
So you're sizing based on the lumen, or with this device would you size it more conventionally with a media-to-media type measurement?
Yeah, well, we look at the distal and the proximal reference areas, and we size it according to there. And we've got a 3.5 distally, it's down from 6 atmospheres. And we then look at the proximal reference, and then we look at the length. Now, it comes in 27 and 37 lengths. Now, ideally, we thought initially we were going to go for probably the 27, but when we actually measured with the OCT, the length came up at 31. The length came up at 31, so it's just between the two. So
and does it deliver like any of the other stents that we have, or do you need like some tips and tricks with the stiffer wire when it's a little less straightforward than a straight shot like this?
It is, yes. I mean, it's quite a stiff. It goes through all the normal technology. It goes 6 French compatible. You can't get it through a guideliner, unfortunately. And because of the outside sort of polymer or coating that actually keeps it in place, it is quite stiff. So I think in tortuous vessels or very angulated right coronary arteries, it can be tricky because it's a very stiff device. It's not particularly deliverable. So again, it's all about lesion preparation beforehand. It's also not advised when there's a very, very heavy burden of calcium, just because the risks of A, delivery, and B, you may not get the best result in terms of the expansion.
Are you going up with an NC balloon?
So there, you may have written, no, we've just taken a 2.5 SC, and we're now going to go up with an NC. You may have recognized, you may have seen the waist with the 2.5 at 20 atmospheres.
Yeah, and the OCT did show that calcification, so I think the prep is going to be good. Definitely.
Yes, so exactly. So there is it's not circumferential, but there is an arc of calcium between 3 o'clock and 6 o'clock.
Yeah, so we're going to now go straight with a 3.5 NC. We're using the Emerge Boston balloons, which is our kind of workhorse balloons at the moment, and we're going to use that to both also just confirm the distal size.
And in terms of the characteristics,
the ideal is it's a bit like with the.
Sorry, go ahead.
Well, I was just going to say it's a bit like I think with the experience with the BVSs, that I think lesion preparation and one-to-one predilatation is mandated really.
I was going to say in terms of the characteristics of the stent for radial strength, it's not like the peripheral stents where it'll sort of have a fair amount of radial force exerted outwardly, right? It tends to be a little bit less outward exerting force, or am I mistaken at that?
I mean, it obviously has some outward exerting force. I mean, there were, there have been over 2,000 patients in registries and randomized trials, and a lot of them have got imaging follow-up and stuff, and there isn't the evidence of ongoing expansion and disruption of the vessel. It really opposes the wall. It's not designed to actually expand or kind of dilate up a lesion, which is why pre and post preparation is so essential.
Got that.
Okay. So this is now a 3.5 non-compliant balloon. That's 12 atmospheres.
Come down.
Down from 12, and we'll hit it harder, more proximal. Cool. So we're just going to predilate with the 3.5 because the most important thing is predilating actually where the lesions are tightest. And there we're getting nice expansion now, up to 16 atmospheres.
That's looking better.
Yeah. We were quite. It was only 2 quadrants of calcium on the OCT, so we had the rotablator on standby in case it was needed, but it doesn't look like we're going to need it.
Robbie, while you're working, I just wanted to take the time to introduce the panel and the moderators that are with us.
Yeah.
We have Dr. Kapoor, Dr. Roy, Dr. Hassani, Dr. Kaganti, Dr. Mahajan, Dr. Sitaram. I think Dr. Goel's up there too. Dr. Neeraj Balla, and Dr. Kumar. So we have a pretty solid panel here. So any comments from the panel?
Big panel, yeah. And
And this is dilating nicely, actually,
18
with
and
the 3.5.
down. If you take the device, yeah. Let's just pull back into go and check nose. Let's just do a little quick
So the
test.
ECG is pretty silent. We'll just do a quick, let's just do an acquisition, maybe, just so,
Yeah, okay.
off we go.
Nice.
So there's good flow, and I think I'm reasonably confident that the calcific part of the lesion has dilated well.
Definitely.
So now we were going to take the device. So we're taking a 354537.
Yeah.
So
So we're going to go for the size 3545. So the smaller number is the distal diameter. It's on a stepped balloon as well, so the actual proximal part of the stent is actually bigger. So this is very nice for these kind of tapering ectatic vessels like this, where, I mean, there's obviously always a risk of edge dissection distally in any such device, but what's that? That's a device.
This is the device, yeah.
But, and you'll see when the balloon expands proximal to distal, and it comes up quite big proximally. So you need to be slightly careful that if you've got if the vessel is kind of at the edges of the size, that what you don't want to do is you want to have a lot of space proximally, because you'll notice that the proximal edge of the balloon comes beyond the stent. So there's a possibility if you're in quite a tight sized vessel, then there's a risk of proximal dissection from balloon trauma, as you'll see when the balloon goes up.
What we might do is just go super mag when the stent deploys, so you can see angiographically what it looks like.
Yeah. And it's the usual things. You just you'd be very, very careful when you're advancing it, especially such a long one. And you'll see it's very, very stiff. So we're lucky here because there's a nice run in, and it looks deliverable. But it's a very, very stiff device, so it can be tricky to deliver. Obviously, because it's quite bulky. Also, the normal care about air entrapment. And then once you dilate, you don't need to go to super high atmospheres. You just dilate slowly and steadily.
Have a take a look.
A little bit further, I think.
So our proximal marker is that large first septal. We've got quite a lot of room. I'm just pushing it on a little bit. A little bit further, I think so.
Does this foreshorten, and what about side branch accessibility?
I mean, it was actually, side branch is really nice. It was actually designed as a side branch stent. You've got these kind of, the connectors are, they're disconnecting crowns.
Okay,
yeah, should we go up there?
I'm going to go up there. I'm just going to do an acquisition.
Sorry, I'll answer your question in a moment. So I'm just going up slowly. And in a minute, you'll see the balloon going up, and then you'll see it suddenly, the sheath come away. There. And you see what I mean about the balloon coming proximal, so you really want to make sure that you don't traumatize the vessel proximally. Quiet there.
And come down. So the patient's having a little bit of chest pain, so we're going to come down.
10. And then the key here is go on to normal mag. So when so obviously the sheath is now trapped behind the stent, so you need to be very cautious. So you back your guide out a little bit. We're using purposely a non-aggressive guide here. So we've got our Judkins guide, so Robbie can hopefully back the guide out. And because as you pull, you just need to have gentle, it's a bit like pulling out a jailed side branch wire. You just need to gently pull back. Just so they come down slowly. Obviously the balloon's it's quite a big balloon and it's quite viscous, so we just need to give it lots of nice time. That's it. And the stent's actually got markers on it, so you can see the proximal and distal edges. And what we'll do is we'll mag up and we'll show you the sheath in my hand and outwards.
So I had to put a reasonable amount of traction with my left hand on the guide, just to ensure.
Is there any way that when you take it out, you could zoom in on what it looks like after it's deployed, so that we can just...
Yeah, definitely. I'll do that. I'll show you my hand. So in a minute, I'm going to put it onto my hand.
So can I have some nitrate, please?
Does he need some morphine? Can I have some morphine, please?
Well, you've got some pain in the chest, have you? Hmm? Yeah. Hmm? Yeah, I use bad.
Some morphine and some diet.
Yeah. We give another milligram of Midas.
So if you can just zoom in on my hand.
We'll give you some painkiller for that.
Can you zoom in on my hand? You got that?
Let's give some nitrate.
So it's quite difficult to see, but you can actually see there's the polymer there that's actually, sorry, not the polymer, the sheath, which we've actually disconnected away. It's quite difficult to demonstrate it, but so this actually comes out of the body. There.
Yep. We could see the split, yep.
Yeah, there you go.
So you can see that there, yeah? So that's the balloon, and that's the sheath that was holding the stent in place.
Yeah, so we're just giving the patient a little bit of morphine just to settle him down. He's actually got a combination of back pain and
then I think we'll post-dilate, so let's take the 3.5.
But the ECG is silent. I'm just going to do a quick angio so you can see what we've achieved. Can you go to normal magnifying, actually, normal, yeah.
The guardian, okay.
Looks great.
Some more contrast.
And this is a
now we're going to post-dilate with a
3.5 device?
And 6.5 millimeters. But the very nice thing about it is it's the self-opposing. So in the Apposition 3 study, which was a randomized trial in STEMI, and they did OCT follow-up, and they really found that the degree of, especially in STEMIs and other cases where you get a lot of vasospasm, you get a lot of thrombus in the vessel, that when that all melts away, there was actually a huge, and we probably all of us undersize our stents in STEMIs, and this really overcomes a lot of those problems, and there was a real improvement in terms of stent apposition on the follow-up studies, which was very nice.
So I'm just post-dilating the distal portion of the stent with a 3.5 NC.
Yes.
And then we're going to take a larger balloon for the proximal segment. We can take a 5.
Now, please. Yeah. So you can see the markers on the stent, which actually make it very easy to post-dilate. So just come back a little bit, I think.
Pardon our ignorance, but is this a drug-coated platform, or is this?
It is.
Sirolimus, yes.
It is.
Sirolimus.
It's coated with sirolimus.
Sirolimus.
16. Nice.
Good. Down.
And maybe come back. Go up.
Go up.
Atmospheres.
Down. Sorry about the pain in the chest. We're just stretching the stent up, sir.
We'll take the 5 out. Go up there. No, we'll just take the other one, yeah.
We'll just take the 5 out.
Okay, normal mic, please.
So we're now taking a 5 NC to the front end, because we know that the reference vessel time, MLD, is about 5.5.
But what we're hoping is that, I mean, the main area where you need to really post-dilate is the area where the lesion was, and we're hoping we don't need to take a kind of a 6.0 stent or a 6.0 NC balloon, because we obviously know the potential dangers of those. So we're hoping that the proximal bit of the stent where it's ectatic will actually oppose itself. And we'll obviously do a live OCT run to hopefully demonstrate that.
So that's after 3.5. We're just now going to take the 5 now. Now,
the other thing is, do you think we should take a
I would just watch that distal wire.
Take the 5 all the way down. Yeah.
Yeah.
Thank you.
And how often do you find yourself using this stent? You've had a lot of experience with it, or?
I mean, it's certainly not a kind of a first line stent, and I don't think anyone advocates it as a first line. But certainly in ectatic vessels, we have quite a lot of patients with sort of vasculitic disease, Kawasaki's, that sort of thing.
Yeah, we are
STEMIs with our vein grafts. Basically, when you've got a high thrombus burden and you've got an ectatic vessel, it's really very difficult to know what's the actual size of the actual reference vessel. You know, where is your normal vessel? And using this device, it kind of overcomes some of that, because at least it, you know, especially in the right coronary artery, where it can be notoriously difficult to undersize your stents, we use it in that kind of situation. So it's a nice thing to have on the shelf. It's not a workhorse, but it's a nice thing to have for these particular situations.
We've got maybe 6 here.
Yeah, is this the 5?
Yeah, there's just
okay, just see the mag for me, just so you can see. Let's make sure we're, yeah.
That's in the middle part.
I've got to prep you properly. Sorry. There's too much air in here.
Are you planning to image this after?
We are, no,
we
but we want you to see the conformity rigidity of the stent, which is actually beautiful imaging.
The second one, it's not attached properly. Can we have another indiflator, please?
Give me some contrast. Yeah. Should we go up there? Just to 6. Come down.
That's down from 6 atmospheres, but it's just a 5mm emerge NC balloon.
Evan, just cone in for me. I just want to get the front edge.
And you can see the marker on the stent there, which allows us to really hit the proximal stent very nicely. I think you're a bit beyond it there. You go forward a little bit, Bobby. I think you're outside the stent. That's it. Yeah. You can actually see how the stent started to take to the shape of the vessel.
Yeah.
Yep, 14.
Yep. It's 40 atmospheres.
And down. So we're hoping that when we measure it, the stent diameter will be considerably bigger than the 5mm that we've post-dilated it to. In fact, maybe just do, Robbie, do on Supermag, just do an acquisition with no contrast, just to look at the stent. If you just go onto Supermag, just do an acquisition there, Robbie. I don't know whether that projects, but you can start to see the front end of the stent there is really looking very big.
It looks great.
Can you appreciate that?
Yep.
Yeah. So we're going to quickly put the OCT catheter down and show you what it looks like. And hopefully convince you that, you know, the actual apposition is pretty good.
Let's see.
We've actually learned, I mean, when the early day, we put a lot of these in and we were quite paranoid and we were doing OCT follow-up on all of them at 6 months. And what's we've learned is that they do actually accommodate to the vessel, where the vessel's been very big, which surprised us.
Robbie Tame, this is Sudhir.
So we'll now switch to the...
Hi, Sudhir. Good to hear from you.
Great to see you. Just a quick question. What is this? I've seen a new iteration of stent. I think it's something called Serpentis. Is this the same thing, or this is different to the?
This is the Expedition S. So this is the one with the. This is the one that has the. The old version had a kind of a retractable sheath mechanism, which was really very clumsy and difficult to use. And we started with that one, but this is much easier. You can basically deploy this like a normal stent.
So, but both are sirolimus eluted, right?
Both are, yeah.
There is a bare metal version, but not really in that much wide use. So we're just getting set up for our thing. We use our co-registration system, which means that we acquire at 15 frames a second, and then we can. Are you ready, Josh?
Just going live now, yeah. Do you flush?
Flush the sidearm. Okay, you want to do the injection?
Yeah, I'll do the injection.
So just flushing the sidearm.
Yeah.
Are you on the OCT picture now?
Yes, we can see it.
Great.
Yeah.
Okay. So enable pullback.
Yeah. So enabled. Inject when ready. Recording.
We've got very good clearance of blood distally.
And we're now going to quickly do the co-registration. This allows us to actually, you can actually then move your marker up and down the angio and see exactly where you are on the, you can see exactly where you are on the OCT. So Josh is now going to do the co-registration.
You know, it's interesting. We were just discussing this, and we have the system as well, and some of our operators have gone away from using it because if you don't do it just by scrolling with that image on the left, you can localize the lens in various points of the artery. So some of our operators use it, some of our operators just do it that way because they have to wait for these 5 seconds.
Yeah. Not good for an interventional cardiologist.
The 5 seconds is far too much.
Exactly. Anyway, so if you now just give us, why don't you just play the whole thing through? Let's see it raw.
Distal to proximal.
So we're now just going to do the pullback, and you can see on the co-registration the little white dot. That shows where we are. And then we're just doing the pullback now. We've got the high res, it's quite slow, there's a lot of data there. So our distal stent is beautifully opposed there, and there's no dissection. And you can see it's really quite a small vessel distally. And there'd be a major risk here. Because of the diffuse atheroma that goes distally, we really didn't want to split the vessel, because then you could easily end up having to stent all the way down the vessel.
And is it just me, or is the difference between this stent and conventional balloon expandable stents, the struts are less embedded, they're just up against the wall?
No, they will embed. I mean, they will, because they kind of oppose very, very closely against the wall. So they absorb in exactly the same way. And you can see here that even when you get slight irregularities within the vessel wall, that the stent is beautifully with it. And in a minute, we'll do our 3D rendering. And you can see here all the way proximally, actually without any further work doing, it's beautifully opposed. No proximal split. So we didn't have to take a very aggressive 6mm balloon. And if Josh is now going to do the stent, you can see there, I think you can hopefully appreciate the technology on this shows that the red dots are the unopposed, and there's almost no red dots at all, which I think for a case like this is pretty impressive.
Yeah, this looks good.
From the technology.
Yeah.
But you can see here there's almost no red dots at all.
Yeah.
That's beautiful.
And now, Josh, if you just do this slide through stuff,
it lies on top, and it'll embed later, which is great, but if there's not, you don't get the sense that it's dug into the wall the same way as a balloon expandable stent might be, which is, I think, the point of it.
Yeah, so we've got our fly-through here, which is always quite fancy to look at. And if you maybe just do the rendered the 3D stent at the bottom and just spin it round so we can see how, if you look at the bottom, Josh, just to rotate it round at the bottom. That's it. So if you actually look at the stent at the bottom there, you can see that despite the irregularities within the wall, the stent actually, it doesn't kind of rip the vessel out the way or doesn't force it. It actually conforms to the anatomy of the vessel, which is why we like it, because it's gentle, and yet you get this phenomenal stent apposition. So I think we're probably finishing our half-hour slot, so we're probably going to tidy up a little bit. I'd quite like to post-dilate that middle bit, maybe with a 4-row NC, so we're going to tidy up. But I think we're pretty happy with that result. And any final comments from the panel?
No, that was a great demonstration. Thank you.
Good. So I think, cognizant of time, because I think we've got half an hour left, we're going to then leave you and switch to our other lab with my colleagues, Dr. Sandeep Kalra and Dr. Devon Patel, who are going to showcase the bifurcation case.
Excellent. Thank you very much.
Thank you very much.
Thanks again.
Hi.
Hello there.
Welcome.
Good morning from Lab 4 at the Royal Free Hospital.
Yeah, hi. Welcome to NIC.
We've got myself. Thank you very much. So we've got myself, Sandeep Kalra, and we've got Devon Patel standing next to me, two of the operators here, and we've got Rahim Kanji, our fellow, standing next to us.
Good morning.
So what we'll do is, without further ado, we'll move straight on to our case presentation. We've progressed somewhat with the case already, so we'll go through what we've done so far. But we'll get Dr. Kanji just to present the case to you now, okay?
Good morning. So the patient on the table is a 6-year-old gentleman with a background of hypothyroidism, dyslipidemia, and a family history of coronary artery disease. He presented some months ago to the Rapid Access Chest Pain Clinic with symptoms of angina. He underwent a CT coronary angiogram which highlighted significant coronary artery disease, especially in the LAD. He had an echo in addition which highlighted a structurally normal heart. He, on the basis of the CT coronary angio, underwent a diagnostic angiogram which highlighted a significant lesion in the LAD proximal to mid. We'll show the diagnostic shots shortly.
Just show that slide first, sorry, yeah. Okay.
Proximal to mid, Medina 110, and some moderate disease in the distal left circumflex, which had an FFR of 0.89, and some further disease in the RCA, which had an FFR of 0.85. The planned procedure was therefore to undergo PCI to the LAD.
Okay, so if we can just switch to the diagnostic pictures now. So we've just taken a couple of diagnostic pictures again now. This gentleman had his pressure wire studies performed about 2 weeks ago. So if we just go to acquisition number 1 there, please, Peter. So this is just the first shot, please, Peter.
We're just going to show the right coronary artery first.
So if you just play that, please. So right coronary artery here and an LAO projection. This was pressure wired 2 weeks ago, and the FFR was 0.85 in that, so we did not proceed to PCI of this vessel. We'll go forward another view, 2 views, please. So there's the LAD here. There was a slightly odd appearance of the proximal vessel just before the first set. We thought it had a slightly ulcerated appearance or fissure-like appearance there. Go next view, please.
And I think that was important because the wire was getting stuck in that particular segment, so it's definitely a fissure lesion.
go forward again there, please. Okay, so in an ARIA cranial view, there's a long segment of mid-vessel disease spanning across the first diagonal. As Dr. Kanji just said, this looks like a Medina 110. It doesn't appear to be any disease in the ostium of the diagonal, but there is some plaque in the proximal course. And next view there again, please. And that there is an eleocranial projection. Again, we can see it's quite a tight stenosis in that mid-LAD. So if we go to the slide, back to the slides now. So the pre-procedural considerations here is that we've got an LAD-D1 stenosis, which is a Medina 110. So we just need to consider how we're going to treat that, what bifurcation strategy we're going to use. There's a long segment of disease in the LAD. We know there's not a huge amount of calcium there. On the CT coronary angiogram, the calcium score is 57, all in the LAD. And then we also had to think about what this proximal LAD, that appearance, what the topography of that proximal appearance was. So if you go forward one slide, please. So our considerations here were that we were going to use OCT guidance here to determine our bifurcation strategy. So we're going to OCT both limbs of the bifurcation and have a look precisely at the ostium of the diagonal vessel. We were considering using our turn track wires, turn track so that we've got easier crossability if we are going to go with a two-stent technique. And then also we were going to use a Xience Sierra stent, which is the new iteration of the Xience stent. And again, the decision to use that here was for the ease of deliverability and the overexpansion capabilities of this stent. In terms of the long segment of disease in the LAD, again, using OCT to determine exactly what stent size we're going to use. With a long segment, we know that it's going to be at least 2 stents in the LAD, so we want to look and precisely deploy our stents and optimize them with OCT. And then very finally, we just wanted to, again, to look with OCT at that proximal LAD appearance to see what's going on. So if we come to Devon now, just we can take you through some of the pictures that we've already taken.
Okay, so if you can have the films after the last image you showed, Peter, just showing there's quite a calcified lesion. Should run number 8, please, thank you. That's it, show that. And that shows there's quite a hard lesion, high pressure required up to 12, 14 bar, just to get the OCT done first. Now go fast forward to the page view, please. Just page view now, thank you. Go further down, post-dilatation, keep going further down. I go back a bit, run number 13, if you can go. Up and up. Further up, that's it. Before that. Yeah, and after. Next shot, next shot. Yeah, thank you. So this is after dilatation. The patient had quite marked elevation. He was pretty symptomatic at this point. We decided to go directly to stenting rather than do any more OCT. Next shot, please. We decided to go for a Sierra stent. The OCT was very helpful in deciding on distal sizing. The distal reference was around 3 millimeters, and therefore...
So yeah, if we can switch to the OCT now. So just as Dr. Patel was just saying there, the reason now that we pre-dilated was just so that we could get enough flow down, that we anticipated that there wouldn't be enough flow down the vessel to clear blood from there adequately. So if we just switch to the OCT now, I'm just going to show you now the diagonal OCT first. So this is the live view now. I'm calibrating with the co-registration now. So that's the proximal LAD into the diagonal. And we'll just let that co-register. We've already assessed this ourselves, but we saw there's no significant disease at the ostium. There was a proximal plaque, but we deemed that not to be flow limiting. So our decision here was that we were going to proceed with a provisional strategy, but our decision was somewhat sped up because this patient became hemodynamically unstable with ST elevation during the procedure.
Typical live case.
So as we screen through here, I mean, we can see this is where that stenosis is in the proximal LAD there. And if we just have a look at the MLA there, we can see with the lumen contours pretty much tracking the lumen accurately. The MLA there is 3.68. So on the side branch, I don't think that's going to be anatomically significant. So I think the decision here not to proceed with a two-stent or bifurcation strategy was valid. And if we just keep coming here, we're just going to be coming up to that's the bifurcation there. So we're still in the ostium of the diagonal, and that's the ostium of the diagonal branch there. And if we just go there again, the MLA there is 4.54. So I think it's a very valid strategy here to go with a provisional treatment. Now, if I cut through from there, so we're still on the OCT, I'm going to go through to the LAD pullback. And this is where the patient actually developed a lot of chest pain because the OCT catheter was obstructing flow down the vessel. So we got a little bit of an impression of what we were doing. Now, normally, my normal practice would be using the data from the Illumian trials, is to measure EEL to EEL to size the diameter of vessel that we're going to put in. diameter stent that we're going to put in, and also use the longitudinal view to decide what length stent we're going to put in. So this is just playing in real time here. Now I'm just going to go back. The clearance was not great again, even though we did pre-dilate. There was still a bit of obstructive flow with the catheter down. So again, if I just put the lumen profile on, we will see that the MLA tightest points, we're looking around at just under 2 millimeters there. Scrolling back through there, we haven't got the best of clearance there just because there was obstruction of flow. And we decided that we were just going to act quickly and try and go distally to size to see what size stent we were going to put in distally. We knew that we were going to have a 2-stent strategy here. So measuring EEL to EEL here, we can see that the vessel distally, the vessel size was 3.12. Understanding that this is a very atheromatous vessel, if we put in a 3.0 stent distally, we would have actually had a bulge at the end of the stent. So we decided to go with a 275 by 38 Sierra stent. So do you want to just show that picture quickly, Devon?
Okay,
we switch to the angiography.
And just
so
one second.
Stent.
1 second before you go, just for the audience, this is a really, really important point because they've measured EEL to EEL, unlike the lumen contour, which gives a luminal area. And if you size only based upon the luminal area, you will grossly undersize if you use OCT in that way. So this is a great demonstration of how you would do sizing, and you discount it a little bit because you don't want to have a distal flap or issue that way. So great demonstration.
And so if we just go back, I mean, with the Illumin 3 trial, the protocol for that is what we were using when we were recruiting patients, that is to downsize by 1/4 of a millimeter. So I think this is a 3 millimeter. We downsized to 2.75, fitting in with the Illumin 3 criteria.
I think it's an important point also here that we were actually going to go for a 2.5 stent. The Sierra is a general stent. You can go from 2.5 onwards to 3.25, same stent.
3.75.
3.75 diameter. So we could have been generous with the stenting, but here we just knew we needed a bigger stent. The OCT helped quite significantly in sizing the distal reference. So I'm just going to switch to the angiogram here. This is the post-stent dilatation film. Please switch to the angio. And you can see there the moment the stent's deployed, we went quite distal because there's disease beyond that septal branch, and looks like a reasonable vessel. And at this point, it's relatively straightforward. Can we flick to the page view now? And really it's now a matter of just getting the proximal vessel referenced with a balloon. Go further down, please. Thank you. And down. And then the second last image, please. No, sorry, page view again. Apologies. Go to that one, please. And that's the stent deployment. Next shot. So on this occasion, again, with referencing.
So if we could just switch back to the OCT again now, I'm just going to show you how we decided what we were treating there. So if we go back to the OCT feed, please. Okay, so we're on the OCT feed now. So I'm in the left main stem on the axial view there, and I'm going to drive distally, and you can see the circumflex just coming in there, and that's the LAD ostium just there. Okay, so if we again look there is atheroma at the ostium of the LAD. Again, looking at what we've got a luminal diameter there of 3.0. Okay. And if I go on, we were planning to land somewhere actually in the LAD just around there. So if I just show you there where we decided we were going to land with the co-registration, the luminal mean diameter is 3.3. When we measured EEL to EEL, it was just over 4. We decided that just because there was so much atheroma there, not just to go down 0.25, but to go to 3.5, knowing that this stent can go up to 5.5. A 3.5 will go up to 5.5. And we're just at the position now where we're going to re-OCT to look at stent expansion and apposition.
So if you could show the last post-deployment film. Actually, we haven't done one, so that's exactly the point. To save on contrast, we've deployed the stent. We're just going to OCT now. So that's the OCT catheter. I've been through this already. It gets stuck at the junction point, just crossing through. It's important to get the lumen downstream, the distal reference point down there. And that's now just beyond the stent, I think. Just 1 second.
We can tell on the live view if we're beyond the stent or not.
Okay, can we see that?
Just come to live view there, please. Okay, so you can come back a little.
The length of stenting here will prevent us doing a single run. Yes, please.
We can do a single run. There's 75. You come back. We're not within stent. So pull back.
That's it.
Still not in stent. There we are. So go forward a bit now.
Okay. So we just.
Okay.
Okay.
Fine. So 15 frames per second, please. So we're going to be. You'll just come back beyond, just go forward a bit, Devon.
Okay, just confirm the guide's engaged properly.
Okay, so let's just do a test clearance there. Yeah, we've got good clearance there.
Okay.
Okay.
Ready to run.
So 15 frames, I'll tell you when, Devon. You're outside the stent, sorry. So you have to just go on a little bit there. If you like
I've gone. Lively.
Okay.
That's it.
Okay.
Okay.
Right. I'll tell you when. Be quiet there, please. Great. So I'll let them take over. What I'm going to do is just calibrate this whilst Devon just talks about what else we've done with this so far and just about the appearance of that diagonal. And then I'm going to go through the OCT live, and we'll just look if we need to postulate any further. We need to look at apposition and expansion.
So we can confirm the pressure that we've been with the 3.5 balloon. So we use a 3.5 in the proximal level vessel at the first septal branch to deploy the stent. We've been to about 18 bar with the 3.5 balloon, 18 bar. And I think that's probably still underdilated. There's also some irregularity at the second septal branch, which will need some further dilatation. So we're going to just see what the OCT tells us, and then decide on the next step. But almost certainly we need post dilatation both at the mid LED point at the second septal and at the proximal septal. The diagonal branch wire is left in at the moment. When you consider removing that at one point, I suspect fairly soon. We'll just see what the ostium looks like on this view.
So just because this is a live case, the co-registration did fail there, but we can still follow the lens marker. So we're just getting into the distal stent there. We're just going to do it by eye, but then we can use some of the newer software on the OCT catheters just to see exactly what's going on. So at the moment, we're just looking at apposition, and we'll put the apposition software on in a second. Everything looks to be opposed there, but we're going to assess that properly with the software. And then we're going to have a look with stent expansion as well. And again, we've mentioned the Illumin 3 trial. We'll look what we did in the Illumin 3 trial and see if we have got proper stent expansion there. So everything's looking opposed so far.
Pity the co-reg.
It didn't. That's fine. That we can. Okay, so even automatically now we can see here between 9 o'clock to 12 o'clock or 1 o'clock. Sorry, we can see that we have got malapposition there. But let's put the software on and actually look at this properly.
Thank you.
So where we see the red markers there now, we can see that we've set our criteria on this to anything more than 200 micrometers of malapposition it will tell us about. So we can see that they're proximal, we are malapposed, and we're going to go back and actually measure that so we can see what we're going to expand up to. So the proximal segment certainly needs some work on it.
Which we expected anyway.
It's picking up some blood there. Those are the red marks just coming. It's just not full clearance. That's all we're picking up there.
Yeah, and it looks like your MLA...
So again, that's just blood there. There's red...
Go ahead.
So we can see just here on the longitudinal view, there's no more red marks there. So I'm just going to go back to the top end here now, just conscious of...
Sorry, the message from the floor?
There was a comment just about MLA.
Yeah, I mean... It's just in that one area, it looks like the MLA is a little bit small, but I can't tell if that's just that one area or uniform or so.
And I think you're talking just around about here. So just going back to where I just measured there now. So the vessel size that we're looking at, I think the stent is pretty much up against the vessel just there. That's 4 rows of vessel size. At the moment, the stent isn't anywhere near that. And we just need to make a decision on how big we're going to go. So the stent, a 3.5 stent is up there kind of just under 3.5. So the decision here we're going to now make is, should we go up, how high should we go up? So just appreciating that there is atheroma proximally, we just don't want to make this go up to a 4.0 and then have to come and treat more proximally, because there's atheroma all the way back. So we just put the lumen contour on there. The mean diameter there is 3.36. So I think if we take a 4.0 there, we're going to angiographically feel that we need to treat further back. So I think 3.75.
Yeah.
So we're going to post-dilate with a 3.75 there.
My feeling is in the angiogram and the midsection we need to dilate slightly higher pressure where the overlap is.
Yeah.
So we're going to take a new 3.5 balloon. Typically, with lack of apposition, we're having difficulty using an old 3.5 NC balloon to go through the proximal struts, and so we're going to get a new balloon, 3.512, to go through.
So just in terms to get apposition to that lumen, it will be 3.75, just as I've shown down the axial view.
We can use a high pressure with this. Okay, that's the balloon ready.
I'm sure you guys are winding down, and just wanted to let you know you guys have about 5 to 7 minutes left, satellite time left.
Okay, we'll just...
So we're going to quickly post-dilate. Thank you for that. We're going to quickly post-dilate, do another run, and then what I want to do is just go through the stent expansion software on here and just show that we've expanded our stent appropriately.
3 balloon. Control Y.
Y fixed.
Thank you. Okay, so this is a new 3 balloon. Hopefully she'll go through. The first balloon was getting stuck in the proximal struts, and that's smoothly through. Can you go up to the midsection, please? Thank you.
Go up there.
6, 8, 12, 14. 14 atmospheres.
14.
And down, and then we'll do the next section there. Go up there, 16.
Any reason to keep that diagonal wire still? Or we can get rid of it?
I think we can lose that wire. I think it's a reasonable point.
Thank you.
That's the diagonal wire out. Okay, so there's definitely lack of apposition at this point. Go up there, 16 bar, 20. 20 atmospheres, that looks better. Down.
This is top end.
The proximal section here, 20 bar. 22, and down. Can we come to the AP caudal, please, just to confirm we've covered the ostium? Stop there, thank you. Tower down, cone in, please, double mag. Okay, I'll use double mag here just to confirm the position.
That's a very nice tool, and we often teach our fellows the exact same thing.
Yeah, 20 bar, please.
Okay, 20 bar there, okay.
Down, please, thank you. Off mag,
right.
Single mag rather, back to the cranial view. And we'll do the final OCT at this point. Note that I'm not going to check with contrast again to limit contrast, so we rely on the OCT as a way of telling us where we are. To limit contrast, you should avoid just doing check angiograms in between unless you have a clinical problem. Okay, so OCT catheter is ready. If you've got about 3-4 minutes, we should be able to complete the OCT.
Yeah,
perhaps not get the
take your time. I think we're doing great, so we'll just see the final OCT with the expansion.
Fantastic. Yeah. So, I mean, if I just, whilst we're getting this OCT ready, if I just ask the panel there, I mean, do you regularly use OCT to assess adequate stent expansion? Because I think the data's still evolving here. It'd be interesting to see what the data from the forthcoming Illumian 4 trial will show, but do you regularly use OCT to assess for adequate stent expansion?
Come forward.
I think it's a little mixed. We just heard some data from the overall India experience on the use of imaging, and it's increasing, but still relatively small. I do think, we tend to use a combination of either IVUS or OCT, but imaging as a whole to assess is, I think, certainly recommended for overlapping stents in the LAD.
Yes.
Okay, test please, thank you.
I think the way I look at it is if you're treating a proximal LAD or a mid-LAD, you want to sort of have the ability to provide outcomes that are equivalent, if not better, than the Lima, and so imaging is almost mandatory in a subset of that nature.
I've got good clearance. We just need to go beyond the. You need to go beyond the stent.
Yeah, we haven't done anything too.
I want to see the end. We just get the whole thing because we're going to do the whole stent expansion. Okay.
Okay, ready to go. Yeah.
Just come back a tiny bit. Otherwise, we won't get the whole thing in. Just come back a tiny bit. So just that's fine. That's fine. There.
Sandeep, if you could show us the OCT screen, that'd be great. Perfect.
If you switch to OCT now, please.
I'm less concerned about the distal margin, which we haven't touched this time around, but we'll try and get the whole one run to show the whole thing.
Yeah. Okay, so we're on the 75 millimeter survey. Okay, so I'll tell you when, Devon. Okay. Acquire there, please. Fine, we've got the whole stent in, which is good. We get the catheter back.
How much of contrast are you injecting?
So we'll just let that buffer quickly.
With Mark.
So if I've got just up on the camera here now, we use these 20 ml syringes that we can actually put the thumb in and get a slightly higher pressure with. And these syringes, I put about 12 mils in, so it wasn't full up to 20, but it's a 20 ml syringe, but it allows you to put 12 mils in. It's what I normally use for an OCT run.
It's all going well.
Okay, good. So let's just have let's just look at the proximal end first now for the apposition. That was what we were concerned about. I think that's looking a lot better than it was. Let's just put the apposition software on, and let's just see where we are. So this is fantastic. There's no red dots in the proximal bit where there were some before. Okay, one there, just one or two, but I think I'm very happy with that. So let's now So with the Illumian 3, we were dividing the stents into two different sections. So we've used a 23 and a 38.
38, yes.
So what's that? That's 61.
61, well, 60 millimeters.
61. So
Plus the overlap.
So we've gone just distal to the stent as a reference, and now I'm going to come approximately, let's look at the first stent. So the first stent was 38, so let's just have a look. We can see roughly where the overlap was, so somewhere around there. So what we're looking at here is the area stenosis. Now you see there's a question mark that's come up there, and that's just because it hasn't liked some of the edge detection there. Just for the principle of time here, I'm just going to accept that. So it's telling me now the area stenosis is 32%. For Illumian 3, we were looking at less than 10%. So what I want to do is now divide the stent in half, because that's what we were doing in Illumian 3. So we've got 18 millimeters there. We've got the area stenosis of 11%. I'm very happy with that.
So distal vessel is fine.
Yep, so distal bit's fine. We're going to do the middle bit now. And that's got an area stenosis of 26%, saying it may be slightly underexpanded. Again, we don't have robust enough clinical data to say that we should be expanding this more. This is just what we were doing within the trial. So we see 26% there. Then I'm going to come up and just have a look at this bit now. And we've got an area stenosis of 21%. So I think now we've just got to engage, in the absence of data to tell us exactly what to do, we engage our clinical sense there and what the angiographic and OCT appearances look like. And I think we've got a good result there. I wouldn't try and expand this anymore.
I agree.
Yeah, we like it. We like it.
Okay. And so the diagonal was left alone. I think the disease is, the diagonal lesion proximally is moderate. We didn't feel it was significant enough to require stent.
We agree. Looks beautiful.
Well, thanks so much. This is a great demonstration and good thinking on your feet with the LEDs starting to, cause symptoms and the like. But it's a really nice demonstration of the OCT and the measurements as well. So we'll see a lot more of this. Thank you so much for both labs for a fantastic demonstration.
Thank you. Thank you for the invitation as well. Thank you very much.
Thank you, Ajay, and the panel. And thank you very much for the opportunity, and hope you enjoy the rest of the conference.
Thank you again. Appreciate it. Great job.
Thank you.
Take care. Bye.
We off? We have success and regret cases before you go.